Welcome to the 5th season of Look Again, Mental Illness Reexamined. I'm your host, Faydra Aldridge. And this is where my co-host, Melissa McKenna, would normally be jumping in to introduce herself and to say hi. But Melissa is going to be taking a little break this season. On today's show, we're going to be talking about an often misunderstood area of mental health, treatment-resistant schizophrenia. Imagine living with delusions and hallucinations, and despite following every medical directive, the symptoms refuse to relent. It's a harsh reality for about 34% of those diagnosed with schizophrenia. We want to understand why that happens and what can be done when typical treatments just don't work. Joining us today to discuss this complex topic is Dr. Diane McIntosh, a leading psychiatrist, author, and educator. Her insights into treatment-resistant schizophrenia will shed light on the challenges and potential solutions for those affected by this illness. Dr. McIntosh is no stranger to our podcast. Thanks for being here today.
Faydra, it's always a pleasure to spend time with you. Thank you for inviting me.
Thank you. Okay, so before we dive in, let's talk about treatment-resistant schizophrenia. What is it?
The problem is with the definition, and often people use different definitions. There was actually a big review several years ago, the TRIP study, and they actually came to a consensus about what treatment-resistant schizophrenia is. And generally, it was determined to be a failure to respond adequately to 2 antipsychotic medications. And that's usually for at least 6 weeks, with people being adherent. And that's the big challenge. And one of those is supposed to be a long-acting injectable, which, of course, they're underutilized. But the reason I make this point is because we talk a lot about treatment-resistant schizophrenia, but what is it exactly? I don't think everyone agrees on the definition, and a lot of studies that talk about treatment-resistant schizophrenia use different rules to determine what it is.
So how, based on all of your years of experience, how do you define it, or how do you identify it in the patients that you work with?
Well, I think that the TRIP criteria probably has the most evidence because they looked at so many trials and determined by consensus a large group of people that are experts in schizophrenia. And I think the failure to respond adequately to at least 2 antipsychotic medications, making sure that you have a trial of a long-acting injectable, and of course, the biggest challenge being that treatment adherence is often not adequate. People miss their treatments. And that's why it's important to have an opportunity to be on a long-acting injectable medication, because it can help with adherence. It's not 100%, but it can help to make sure that people are continuously getting their medication.
Now let's talk about the long-acting medication. How do people access it? What's involved with that process? And just tell us a little more about that.
The primary treatments that we use for the symptoms of schizophrenia, and I think it's important to say that people who have a diagnosis of schizophrenia often have other diagnoses as well, so they can have depression and anxiety that may need to be treated as well. But for the primary symptoms of schizophrenia, generally people require an antipsychotic medication. Those can be taken orally, so you take them every day. But they can also be taken in the form of a long-acting injectable. So instead of every day, you have to decide whether you're taking your medication or not. Maybe if they work well for you, you only have to get an injection once a month, once every 2 months, or once every 3 months, depending on the medication. And these medications work the same way. They're the same. They're antipsychotics, but they're delivered in a different way. So it helps with adherence so long as people go for their next injection. Yeah. But they've been shown to be really very valuable for patients who are living with schizophrenia because, again, it makes it easier for them to make sure that they're adherent with their treatment. Generally, they're really well tolerated.
So what are some of the most common symptoms that you see in individuals with treatment-resistant schizophrenia?
Well, all of the symptoms associated with schizophrenia can be part of the presentation of treatment-resistant schizophrenia. So the positive symptoms are having delusions or false beliefs or hallucinations, usually auditory hallucinations. But people with treatment-resistant schizophrenia can have persistent negative symptoms as well. That's things like having difficulty with your get up and go, avolition or apathy. On top of that, the cognitive symptoms are commonly a part of treatment-resistant schizophrenia. So any presentation of schizophrenia that persists despite treatments that are taken regularly at optimal doses, those can be part of treatment-resistant schizophrenia.
Who do you think could be at risk? Or let's talk about the people that could potentially be diagnosed with treatment-resistant schizophrenia.
So there's actually been a fair amount of research on who is at greatest risk for developing treatment-resistant schizophrenia, and it's a little all over the place. So individuals who have an earlier onset of schizophrenia symptoms are at greater risk. And that's actually true across all psychiatric disorders. The earlier the onset, the more likely it is that there's a more pernicious course or a more difficult course. You're more likely to be treatment resistant. It also speaks to why it's so important to get help early and to get on treatment early because you want to protect that brain. So we know that you're more likely to have treatment resistant schizophrenia if you have a more severe kind of presentation, which often goes with the earlier onset, unfortunately. If you have a familial pattern of schizophrenia, so there are other people in your family that have schizophrenia diagnosis, and we can talk more about the genetics underlying schizophrenia as well. Strangely, more often associated with people who live in rural areas rather than urban areas. And that's been a fairly consistent finding in different studies. And I'm not actually sure why that is. Yeah. There's some studies that show males are at greater risk than females, but then other studies that have not found that to be the case. Poor social functioning and premorbid functioning. So before the symptoms started, if you already were struggling with your social abilities and getting along with other people, and as well, specific cognitive deficits. So individuals who may be already challenged with the way that their memory, their concentration, maybe having a learning disability, are at greater vulnerability for having treatment-resistant schizophrenia.
What current research is happening when it comes to treatment-resistant schizophrenia, and what additional research do you think we need to continue addressing this?
As we talked at the beginning, just having a consistent definition of treatment-resistant schizophrenia is so important. But I think the most important thing is that we explore other opportunities to help people who have treatment-resistant schizophrenia, supporting people with their adherence, of course. So making sure there's a community that's educated around them, whether it's an assertive community team or family members are engaged as part of treatment so that they can support. We tend to rely heavily on antipsychotics, but we've learned now, and there's more research that needs to be done with combinations of treatment that can help people who have treatment-resistant schizophrenia. For instance, sometimes people use combinations of antipsychotics. These have to be rational combinations. They have to make sense. So using two older antipsychotics together, all that does is cause more side effects. Whereas using medication like clozapine with one of the newer antipsychotics that work in a different mechanism, sometimes that works to help to reduce side effects or can be more efficacious. An example would be clozapine and Abilify in combination. There have been some studies showing a combination of clozapine or an antipsychotic with ECT can be very helpful. ECT scares people, this idea of having electric current to your brain, but it has been shown to be incredibly effective. In fact, the gold standard for treatment for depression, but also can help with mania symptoms, and in combination with an antipsychotic has been shown to be valuable for some patients who have treatment-resistant schizophrenia. As well, using mood stabilizers in combination with antipsychotics. And there are studies showing that there are some benefits from those combinations as well. So I think what we need are two things. One is studies showing in the right population, meaning they all have treatment-resistant schizophrenia, and we're doing our best to ensure that they're adherent to their treatment and looking at larger studies that show the value of these combinations, but also finding better quality drugs. Because the problem is, we don't have the best drugs in the world. People don't like taking them. And research is very limited in finding new medications for the treatment of schizophrenia or any mental illness.
Tell us a little more about clozapine and its impact on treatment-resistant schizophrenia.
Clozapine is actually the only drug for schizophrenia that has the indication for treatment-resistant schizophrenia. That means that Health Canada, the FDA, have found that there is sufficient data to say that this drug is particularly valuable in individuals who have failed other medications. But only about 30 to 60% of people actually respond to clozapine, which means that there's a whole lot of people that don't respond to clozapine as well. And the other thing about it is that it is a difficult medication to take because it requires monitoring of blood work. But there's other side effects like cardiomyopathy or problems with your heart muscle and weight gain and other frustrating side effects. But it is an extremely effective treatment, which is why it's so highly recommended. Not only does it have data for positive and negative symptoms, but also reducing suicidality, reducing the risk of violence, improving quality of life. So I think most people who spend their lives treating schizophrenia wish that we started clozapine earlier. We want to get treatment started fast with something that's more likely to be better tolerated. Some of the newer antipsychotics, if those aren't working, get a long-acting injectable on board. Those, again, made with those newer antipsychotics. And if those aren't working, get on to clozapine. And then if clozapine isn't working, which sometimes happens, a clozapine-resistant schizophrenia, making sure that you're dealing with all of the other potential comorbid conditions and then doing those combinations that I mentioned earlier.
Now, you were just talking about ECT. What about transcranial magnetic stimulation? That's something we're hearing a lot more about. What role do you think they can play, both ECT as well as the transcranial magnetic stimulation, in managing treatment-resistant schizophrenia?
So RTMS has data, certainly in depression, can be used for moderately severe depression. That medication isn't working. ECT really is the gold standard. It takes a lot of time, but it doesn't hurt. It's just a lot of commitment. So most of the data is absolutely in depression. I know there are some schizophrenia studies. We also have to remember that people who are diagnosed with schizophrenia do struggle with depression, with anxiety, and sometimes there is confusion. People are said to have treatment-resistant schizophrenia, but we've actually missed a comorbid condition. We've missed the depression. We've missed the anxiety. We've missed the ADHD. Yeah. We've missed the substance use. And of course, substance use disorder can color any mental illness and make it really confusing. So I think it's really critical that we ensure we have the right diagnosis. And some of those combination treatments may actually be benefiting not just the core schizophrenia symptoms, but also the comorbid conditions as well.
You're listening to Look Again, Mental Illness Reexamined. Today, we're exploring the complexities of treatment-resistant schizophrenia with psychiatrist Dr. Diane McIntosh. If you're just tuning in, we've been discussing the challenges of treating this condition, as well as the underlying factors behind it. So, in addition to medical treatments, let's talk about psychosocial support. How important is psychosocial support for individuals with treatment-resistant schizophrenia? And how important is it to have that comprehensive treatment team rallying beside you and behind you?
I think we have established clearly that social support is the greatest protector of our mental health.
If I could clap, I would right now.
It's absolutely the case. And some people are very fortunate to have loving, supportive families around them, and other people aren't. So this is why I've changed the way that I think about this to supporter rather than saying family. But if you're lucky enough to have a family member or someone that you really care about, who can be part of the process with you and your care, it makes a huge difference for that individual. It makes a huge difference for me. And it's one of the first questions I ask patients when I'm meeting them for the first time is, who do you love? Who is your main supporter? Can they be part of this? And getting that permission as early as possible to be able to include that person. It's also because I see people who are very ill. They're on sometimes combinations of medications. And if someone they love and care about, their supporter, doesn't understand where I'm coming from and why we're trying all these different things, that can make them move from supporter to detractor. Who's this McIntosh woman? Why is she giving you these drugs? Does she have horns and a nicky tail? And that's why I want people in to say, this is why, this is a process, this is why we're doing this. And then they can also be not only a supporter of that individual, but also an early warning signal to me. If something's not going well, we have already established that they have permission to reach out, and then I can reach out to the patient and get them in earlier.
Yes, Dr. McIntosh, there again, the importance of that circle of care, both involving the individual, a caregiver, or a family member who is so supportive and part of the journey, as well as you and other clinicians directly involved. We just can't forget that. You spoke earlier about the genetics of schizophrenia and the impact of treatments on treatment-resistant schizophrenia. Let's get into that a little bit more.
So this is an area of incredible advancement over the last many years, not just in schizophrenia, but in all psychiatric disorders. There's genetics underlying schizophrenia, but there's also environmental factors. So why does someone have schizophrenia? Well, part of it has to do with some genetic risk. The genetics of psychiatric disorders are different than the way we usually think about the genetics of other disorders. So think about cystic fibrosis. You have to have a gene from mom and a gene from dad in order to have cystic fibrosis. Then there's disorders like Huntington's disease, where you just need one gene from your mom or your dad. And if you have that gene, you will have Huntington's disease. The way psychiatric disorders work, like schizophrenia, is there's a number of different genes, and different studies have shown that now there's actually a limited number of genes, all of which have some impact on the likelihood of you developing schizophrenia. And if you have a mom and a dad who both have some kind of family history, have some of those genes, the more you end up getting, the more you inherit from mom and dad, the more likely you are to have schizophrenia. The reason this is so important is because if we understand what genes are responsible, it can help to develop treatments for schizophrenia. So it's a huge opportunity as we understand more and more about the genetics of schizophrenia. It helps to drive research on new treatment.
And that would just explain why it's so incredibly difficult, because there's so many factors in treating schizophrenia.
There are. And for treatment-resistant schizophrenia, it appears that there's different kinds of heritability. So you remember earlier I was mentioning that having a strong family history of schizophrenia may make you more at risk, or it appears it makes you more at risk of developing treatment-resistant schizophrenia. That has to do with that genetic basis, that you have probably inherited more of those different genes. And each gene isn't really all that valuable alone or that powerful alone, but the more that you inherit, they work together to have a more powerful effect. So if you've got mom and dad, both who maybe not even aware that they have that family history, but they carry those genes and you've inherited them, that puts you at greater risk.
What role does brain chemistry play in treatment-resistant schizophrenia?
That is not entirely clear, but it does appear that there is a risk associated with different responses of dopamine receptors in individuals who have treatment-resistant schizophrenia, which means because the antipsychotics that we have now work by being modulated, or the dopamine receptors are affected by the antipsychotic. That's how they work primarily. There are some other neurotransmitters that are involved, like serotonin, but the primary way they work is through dopamine. And so if you have treatment-resistant schizophrenia, that means the usual medications aren't working appropriately or effectively. And that may be because your receptors are not responding the same way as people who don't have treatment-resistant schizophrenia.
Now, as we look to the future, what advancements in research or treatment are you the most hopeful for when it comes to treatment-resistant schizophrenia?
I'm what you call an early adopter. So I'm always looking for new treatments in my toolkit. And in psychiatry, they come very, very slowly. And I just learned that there is a new treatment for schizophrenia. It's called Cobenfy. It's in the US, not in Canada. It is the first new mechanism of action in schizophrenia in over 30 years. This is a big deal, and it's been shown to be beneficial for both positive and negative symptoms without some of those really challenging side effects. Now, you always have to be very careful about that because every drug comes with side effects, but one of the greatest challenges in taking an antipsychotic medication has been the metabolic side effects, weight gain, impacts on sugars and on your lipids. And it appears that this drug does not have, from the clinical trials that have allowed the FDA to approve it in the US, no significant weight gain and low rates of treatment discontinuation. The long-term effectiveness will come with time as it's used in the US and continues to be part of trials. Interestingly, as I mentioned, schizophrenia, the neurotransmitter, the brain chemical that we tend to think about first, what makes this drug different is that it blocks dopamine receptors the same way, but the impact on dopamine is indirect. So it's an oral medication, hopefully coming to Canada sometime soon.
Well said. Dr. McIntosh, thank you again for sharing your valuable insights with us today. It's clear that while treatment-resistant schizophrenia is difficult to manage and presents significant challenges, there are signs of hope that we are making progress, and ongoing research will just continue to help us better understand and address this very complex condition. So thanks for your time and for being here today and for once again providing us with this very important information.
It's always a pleasure. Thank you, Faydra.
And to you, our audience, thank you for joining us. Together, we can better understand and change the narrative around mental illnesses like schizophrenia. If you have any questions or comments, do not hesitate to reach out to us on social media at BC Schizophrenia or at BCSS Youth. To get our latest episodes, be sure to hit follow on Apple Podcasts, Spotify, or anywhere you listen to podcasts. We'll be back with more thought-provoking discussions in our next episode. Talk to you soon.
This podcast is brought to you by the BC Schizophrenia Society and the BC Partners for Mental Health and Substance Use Information. We're a group of nonprofit agencies providing good quality mental health literacy resources to help individuals and families maintain or improve their mental well-being. The BC Partners members are Anxiety Canada, BC Schizophrenia Society, Canadian Institute for Substance Use Research, Canadian Mental Health Association's BC Division, Family Smart, Embody, the North Star Family Services Program, and Mood Disorders Association of BC, a branch of Lookout Housing and Health Society. The BC Partners are funded and stewarded by BC Mental Health and Substance Use Services, an agency of the Provincial Health Services Authority.